Welcome to the March AIDS Clinical Conference, our virtual CROI update that we do every year. This year, the conference was all virtual as well. This morning, we have three outstanding speakers that I'll introduce, and then we'll get started to maximize their time. The first is Jehan Budak, who is a faculty member in the Division of Allergy and Infectious Diseases at the University of Washington. She is the Assistant Medical Director for Madison Clinic and the Pathway Director for the HIV Pathway and the Internal Medicine program here. She does many things and all extremely well, and she's an excellent speaker. Ruanne Barnabas is our next speaker, who is a faculty in the Department of Global Health, as well as also in the Division of Allergy and Infectious Diseases. She is a world-renowned researcher on HIV, STIs, as well as COVID-19, running some critical clinical trials for therapeutics for COVID-19. And then we have Adrienne Shapiro, who's also a joint faculty member in global health and in allergy and infectious diseases. And she is also doing global work in TB, HIV, as well as COVID-19 vaccine research more recently. And she is also works at the Madison Clinic, same as Ruanne Barnabas as well. So welcome these three speakers, and we'll get started today. Please remember to use the Q&A box for any questions that you have of the speakers. Thank you.
All right, thank you very much for that introduction, Sharisha, and I will get started first, and I will be giving some updates regarding antiretroviral therapy. So for the next slide, I have no disclosures. And for the next slide, we have an outline such as this. First, I'll be giving an update from the IMPAACT 2010 study, then an update from the Atlas 2M study, and lastly, talking about Lenacapavir. I am excited to share, especially options number 1 and number 2, because both IMPAACT 2010 and Atlas 2M were shared at CROI 2020. But I think because of the COVID pandemic, these haven't really been discussed as much, so I'm very excited to give updates on both of these. So for the next slide, we will start off with IMPAACT 2010. And for a bit of background about this, and the reason why I wanted to choose this was that ART options in pregnancy remain quite limited. I think we know that, a lot of us use tenofovir, disoproxil fumarate as a backbone NRTI, a lot of raltegravir, efavirenz, and now more dolutegravir use is being seen. However, we are aware of the saga that was associated with dolutegravir neural tube defects, which is less of an issue now. However, I want to share about the IMPAACT 2010 study, which is a global multi-center randomized trial of ART-naive pregnant women between gestations 14 and 28 weeks with newly diagnosed HIV who were ART, as I mentioned, naive, who were started on TAF-FTC and dolutegravir, or Descovy dolutegravir, versus TDF-FTC plus dolutegravir, or Truvada dolutegravir, versus TDF-FTC, efavirenz, or ATRIPLA. And this is meaningful because this was actually the first time TAF was looked at in a clinical trial in pregnant women. So for the next bullet point, the interim results from IMPAACT 2010 were shared at CROI 2020, and that was through their delivery outcome. There they found that dolutegravir containing arms had superior virologic efficacy, and that the TAF-FTC, the Descovy dolutegravir arm had the lowest rates of adverse pregnancy outcomes. Specifically, they found that preterm delivery and small for gestational age had the lowest rates. So for the next slide, this was the actual study design. I know I mentioned this already, but I wanted to show again that the three arms were Descovy dolutegravir versus Truvada dolutegravir versus ATRIPLA. And this was during pregnancy and in the postpartum period. As you'll see on the bottom, this is sort of the timeline of the study. And then what is significant about this updates from this CROI is that we have data through 50 weeks postpartum. So for the next slide, I wanted to share some of the maternal baseline characteristics, and we've got an animation around the total bar as well here that shows, this is where I really wanted people to focus, that there's 643 pregnant women that were enrolled. The median age was 26. 88% of people were actually enrolled in Africa. The gestational age was 21.9 weeks. This mean CD4 or the median CD4 count was 466, with a median HIV RNA of 903, only 16% of whom had a viral load less than 50. And here it says that 83% were were on ART in pregnancy prior to entry. Now, this is a little confusing because I mentioned to you just a few slides ago that this was a group that was ART naive. However, what they allowed was for people to still enter the study if they had been on ART for 14 days prior to study entry. And so thus you'll see that the median days on ART for those who were already started on ART was 6. So this was still people who were either ART naive or had just been on ART for less than 2 weeks. So for the next slide, I wanted to share that these were really the 5 big things that they were looking for. First, they were looking for virologic efficacy between the 3 arms, and then they were looking at safety outcomes, specifically looking at maternal and infant grade 3 or higher adverse events, infant mortality, and infant HIV infection. Now, they did also happen to look at weight, which I won't focus much on at all, but I will mention again in the summary. So for the next slide, I wanted to share some of the first results. So this is for virologic efficacy. And first, I'd like people to look at the left, where on the x-axis, we have the sort of the gray, which is the combined dolutegravir arms, and the purple, which is the atripla arm. And on the y-axis is the percentage of whom had RNA suppression at week 50 postpartum. And this is again looking at maternal RNA suppression, because ideally we are trying to avert any infant HIV infections. And as you can see, the 3 arms actually were non-inferior. Now on the right side, there is an image of maternal virologic failure. Again, on the x-axis here, they've actually separated the dolutegravir arms so that the Descovy dolutegravir is in the dark gray, the Truvada dolutegravir is in the light blue, and that the atripla is in purple. And again, on the y-axis is the percentage of whom had maternal virologic failure. And here you'll see actually that there was statistically significant difference amongst the groups, and specifically between the dolutegravir arms and the atripla arm, in which there was more maternal virologic failure seen in the atripla arm as opposed to those on the dolutegravir containing regimens. So for the next slide, I'd like to talk about some of the other adverse events that we mentioned. So this has a lot of things going on this slide. And briefly, this is again, maternal and infant grade 3 or higher adverse events by arm through 50 weeks postpartum. On the y-axis, we have the percent of women or infants with adverse effects. So we'll first look at the far left image. And here you'll see that there was no statistically significant difference between the 3 arms for maternal grade adverse events. Similarly, for the infant grades, there was no statistically significant difference between the 3 arms. Now, there was statistically significant difference between the 3 arms with regards to infant deaths. And as you'll see that the atripla arm had higher rates of infant deaths. And then in a post hoc analysis, they also looked at stillbirth or infant deaths and found sort of a similar trend. On the next slide, we'll share information regarding infant HIV infection. And on the y-axis, you'll see the estimated probability of infant HIV infections. And there were only 4 infants, and only is really the wrong word, but unfortunately, there were 4 infants who had HIV infection, all of whom were breastfed and received ART prophylaxis regardless. There was no statistically significant difference between the 3 arms. And there's not much great information about what happened in each situation. One of those babies, actually, the maternal RNA levels were never suppressed. And then there were a couple questions in the Q&A in the session that were really trying to sort of understand what happened here. And I think what I could surmise mostly was that it was postulated that these infections occurred before virologic suppression, perhaps. But so I suspect that we may get some more information about these incident HIV infections in the infants as time goes on. And for the next slide, I want to just summarize that TAF and dolutegravir were safe through the 50-week postpartum data period. And again, that's significant because there has been a lot of buzz about dolutegravir and its safety in pregnancy. And then also because, as I mentioned, this was the first time that TAF was looked at in a clinical trial in pregnant women. All regimens were safe and efficacious, though I did mention that there's infant mortality was higher in the efavirenz arm and that more women had virologic failure in the efavirenz arm, that nonetheless, these are 3 very safe options for women who are pregnant. Now, the one thing that I haven't mentioned here that I just wanted to allude to is that they did also look at weight gain or weight loss. And I think that that is certainly prescient since there is all this discussion about weight gain with integrase inhibitors and also weight gain with TAF. Now, specifically, they looked at weight loss because during the sort of pregnancy period, most women lost weight. And actually, the efavirenz had the most weight loss. And then, as you can imagine, the TDF-FTC dolutegravir arm had less weight loss. And then the Descovy dolutegravir arm had the least weight loss. However, I think this is just something that shows that there's still some weight changes that go across the board with these three arms. And for my takeaway point, which is the next animation here, is just that the IMPAACT 2010 data provides additional reassuring data about dolutegravir and TAF use in pregnancy and in the postpartum period. And again, this is significant because the perinatal guidelines as of February 2021 now state that TAF is an alternative for TDF use in pregnancy. And I suspect with time that getting information from IMPAACT 2010 will show that it is, again, safe to use. And then dolutegravir is recommended in pregnancy and in the postpartum period as well. So for my next slide and my next sort of study to share with you all is an update from the Atlas 2M study. So on the next slide, we have some background information. So Atlas is a randomized clinical trial that was shared at CROI in 2019, and I think is very significant because it showed that cabotegravir and rilpivirine, long-acting and intramuscularly, Q4 weeks in treatment-experienced people with HIV was non-inferior to standard oral antiretroviral therapy. This is in contrast to the FLAIR study, which was also shared at CROI 2019, which was actually the same use of cabrilpivirine IM Q4 weeks, but in treatment naive individuals. And from the Atlas study, there were 3 virologic failures that occurred. Now, for the next bullet point, I wanted to share that the Atlas 2M study was shared at CROI 2020, so just last year. And this was a study looking at cabril injectable Q8 weeks in treatment experienced people with HIV as opposed to Q4 weeks. And they found that it was non-inferior at 48 weeks. Not surprisingly, participants preferred Q-week dosing as opposed to Q4-week dosing. And in that study, 10 virologic failures occurred, 8 in the Q8-week arm and 2 in the Q4-week arm. And when people failed, they failed with both NNRTI and INSTI resistance-associated mutations. So now for the next slide, I want to share updates up to 96 weeks. Before we do that, I just wanted to quickly sort of show you the study design for Atlas 2M. As you can see in the far left-hand side is the gray box that shows eligible participants. There was a good proportion of individuals who was actually part of the open label extension from the Atlas study, where they then sort of were able to either be randomized to either continue Q4 weeks or to switch to Q8 weeks. And then there was also the Atlas standard of care arm, which was in ART experienced individuals who were virologically suppressed, who had never been on cabotegravir and rilpivirine, who were also able to join the study. So a pretty large study, as you can see, nearly 1,000 people, randomized 1-to-1 to Q8 weeks or Q4 weeks. And there also was a 4-week oral cabotegravir and rilpivirine lead-in. And as I mentioned, as circled in, or as depicted in the red box, we have data out to week 96 now. And for the next bullet point, I just wanted to share some of their endpoints that they were looking for. The primary endpoint that they were evaluating for was the proportion of participants with an HIV RNA greater than 50 at week 48. And other endpoints were looking for incidence of confirmed virologic failure, or VF, which I will sort of abbreviate as from here on out, incidence of viral resistance in participants with confirmed virologic failure, and safety and tolerability. On the next slide, we'll show results of, again, 96-week data. On the y-axis, we have the proportion of participants in percentage. And on the x-axis, we have the different sort of arms looking at virologic non-response, virologic success, and no virologic data on the far right. And I would just like to draw your attention to the middle, looking at virologic success, where in the dark green is Q8-week cabril versus the light blue, which is Q4 weeks. And as I mentioned, we already heard this data at week 48, but again at week 96, Q8 weeks is non-inferior to Q4 weeks. Now on the next slide, I wanted to share some information regarding adverse events or adverse effects. This is a table that I've adapted from multiple tables, and I wanted to share here with you. And unfortunately, I think that most of our references are cut off, and I apologize for that, but they're all in there. And I wanted to sort of put this together into one big slide because I think these are really helpful sort of data points that we might be able to share with patients as this sort of rolls out and becomes part of our sort of tools against HIV. So we'll go row by row. On the left column is the Q8-week arm, and the right column is the Q4-week arm. So approximately 93 to 95% of individuals had any adverse event, but a very small percentage of them, only 3 or 4%, had an adverse event that led to withdrawal. As you can imagine, with regards to the next row, which is the number of injections, there were far less injections in the Q8-week arm as there were in the Q4-week arm, but there were a lot of injection site reactions in both arms. As far as the most common one, I would sort of, if I were to counsel patients, pain is the most common one, seen in 15 to 20% of individuals. And then nodules and discomfort were rarely seen, as you can see at either 1% or less than 1%. The median duration of the injection site reaction was 3, and only 1 to 2% of individuals withdrew due to injection-related reasons. So I think if I'm counseling patients, I'm going to say that injection site reactions are quite common, especially about 15 to 20% of people will have pain there, and it should last about 3 days, but most people will do fine with this. So on the next slide, I wanted to share information regarding resistance, and I'd like to spend a little bit of time on this table. So this is the overall summary of confirmed virologic failures through week 96. On the top row is Q8, or obviously it's the titles, but then the top row is Q8 weeks, and the bottom row is Q4 weeks. So we'll go along column by column. So of the Q8 week arm, there were 522 individuals in that arm, and 9 individuals had confirmed virologic failure. So there's a low virologic failure rate. Now, of those 9, 7 developed rilpivirine resistance associated mutations, and those mutations that were observed was a K101E, an E138 K or A Y188L, and a Y181C. So most of these are pretty significant NNRTI mutations, conferring at least intermediate to high resistance to most NNRTIs. Then you'll see in the next column that 5 out of 9 in the Q8 week arm failed with integrase resistance associated mutations, and those that were observed at failure was a Q148 and an N155. Now, conversely, in the Q4 week arm of, again, approximately 500 individuals, 2 people failed. 1 of 2 got rilpivirine associated RAMs, which was a K101E and an M230L, and then both of them failed with integrase resistance, which was either an E138K, a Q148R, or an N155. Now, as a key on the next sort of bullet point are some of the key points about resistance from this study. So again, the total number of virologic failures from Atlas 2M were 11, 9 in the Q8 week arm and 2 in the Q4 week arm. Between 48 and 96 weeks, there was only 1 additional virologic failure that occurred, and that was in the Q8 week arm. There was, in this person, a K103N and a Y181C was detected at virologic failure, and also retrospectively at baseline in peripheral blood mononuclear cells. There are no INSTI resistance associated mutations present at virologic failure or at baseline, though a substitution L74I was present at baseline in this individual. Now that's significant because if you might recall from the Atlas and FLAIR studies, the L74I was a signature polymorphism that occurred when people failed in Atlas and FLAIR. And interestingly, it's called a polymorphism, but here it continues to sort of, I would say, wreak havoc. Again, 10 out of 11 with confirmed virologic failure resuppressed on an alternative regimen, and all with confirmed virologic failure still retained dolutegravir susceptibility, though I would be very concerned with these integrase resistance associated mutations about using dolutegravir. So for my next slide, in summary, virologic efficacy, adverse events, and injection site reactions were similar in the IMPAACT RIL Q8 week versus Q4 week arms. That confirmed virologic failure occurred in 11 people in total in people with HIV. And 9 occurred in the Q8 week arm, 2 in the Q4 week arm. And most people with HIV with virologic failure acquired both NNRTI and INSTI-RAMs. So for the next animation here, the takeaway point is that Q8 week dosing of cabrylpivirine is effective, and there are few virologic failures, but when you fail, resistance-associated mutations to both NNRTIs and INSTIs occur. And lastly, the final study that I wanted to briefly go through is Lenacapavir, which is the Capella study. So as for a bit as background, Lenacapavir is a novel HIV-1 capsid inhibitor, formerly known as GS6207, that can be given as a long-acting subcutaneous injection. It's currently in development as a component of long-acting therapy for HIV-1 and has activity in NRTI, NNRTI, INSTI, and PI-resistant HIV-1. For the next slide, I wanted to briefly show you this study. Again, I'm quickly going through this because this is a novel agent, and I just wanted to sort of plant the seed and alert people about this. But this was a study where it was of people who had a virologic or viral load that was greater than 400, had resistance to at least 2 agents from 3 of 4 main ART classes, and had less than 2 fully active agents. There were 2 arms, 1 double-blind and 1 open label. Of the double-blind study, it was randomized 2 to 1 with people to add oral lenacapavir as a sort of lead-in for 14 days or continue placebo while they were failing a regimen, and then switch to subcutaneous lenacapavir, which was administered Q6 months for 52 weeks. And this was sort of in contrast to the non-randomized cohort in which they just added oral lenacapavir to an optimized baseline regimen for 14 days and then switched to subcutaneous. Again, sort of having this like oral lead-in to the maintenance regimen. And then for the next slide, which are the results, the primary endpoint that they set out with was % achieving a viral load decline of greater than a half log at 14 days. So again, this is very early data. And as you can see on the y-axis, the % of participants who achieved that viral load decline was 88% with lenacapavir, as opposed to 17% with placebo. And in general, this was a group of individuals with a median age of 52, with a median CD4 cell count of 150, at least with a median number of prior ART regimens of 11 and median number of years since HIV diagnosis of 24, i.e. a highly treatment experienced cohort. And so for the next slide, which are my summary slides, in the Capella study, very early data shows that use of lenacapavir demonstrated antiviral activity against MDR HIV after 14 days and led to virologic suppression when paired with an optimized baseline regimen. For the takeaway point from here, it's that although much more data is needed, lenacapavir has the potential to become an important tool against MDR HIV in heavily treatment experienced people with HIV. And on our last slide, we have some conclusions, and you can just sort of go through all 3 of these animations to share some final takeaway points. And at this point, I will pass it along to Ruanne. Thank you.
Good morning, everyone. It's my pleasure today to talk about the updates from HIV epidemiology and transmission from Virtual CROI 2021. Next slide, please. And there was lots of exciting work to share from CROI. Next slide, please. And I'll start with talking about racial differences in COVID-19 infection rates among people living with HIV in the United States. And the theme for the slides that I will present today are that we continue to have disparities in both HIV and COVID, but we are increasingly seeing both new tools and new approaches to addressing these disparities. Next slide, please. So Dr. Islam presented data that used using EMR data to examine racial and ethnic disparities in COVID-19 infection rates among people living with HIV in the US. And this work was motivated by data showing already that for both HIV and COVID, we have high mortality rates, particularly among Blacks and among American Indians, Alaskan Natives, Hispanic, Latinos, Native Hawaiians, and Pacific Islanders. And the purpose of this analysis was also to look at these disparities for COVID among people living with HIV. Next slide, please. So this is the main graph that shows the result for COVID infections among by race and by HIV status. And you can see here for non-Hispanic whites, the rate of COVID was lower among people living with HIV than people without HIV. But for non-Hispanic Blacks, Hispanics, and non-Hispanic Asians, you can see that the rates of COVID-19 were higher for people living with HIV compared to persons without HIV. And in the next slide, you can see the adjusted odds ratio. And so this translates for a non-Hispanic Blacks, Hispanics, and non-Hispanic Asians to an odds ratio of almost 2. So an adjusted odds ratio of almost 2, so higher risk for acquiring COVID-19. Next slide, please. And so we continue to see racial and ethnic disparities evident among people living with HIV, testing positive for COVID in the US. And there were some limitations to this data. They were EMR data, there were some missing data, but very importantly, these data were not able to look at social determinants of health, like for example, income, employment type, and health insurance. But it is likely that these represent structural inequities to access to health. And there are parallels between HIV and COVID-19 that we continue to see. And in the next set of slides, I hope to present data on how we can address some of these structural inequities. Next slide, please. There was also some encouraging news from the CDC. Dr. Lee presented work on timely access to antiretroviral therapy from 2012, where we had new guidelines for antiretroviral therapy initiation, and timely ART increased from 42% to 82% in 2018. So that is quite heartening in itself. But overall, we continue to see disparities in access. More Black than white people with HIV face lower rates of timely ART initiation. And during the same period, we also saw lower rates of HIV, of ART initiation in the South compared to ART initiation in the West. And overall, people with HIV with a history of drug dependence or abuse diagnosed experienced lower rates of timely ART initiation. So these are, we can also think about these as opportunities for outreach and innovation, which we do so well at the Madison Clinic. But we can also think about now, what do we need to do to achieve equity in access to antiretroviral therapy? Next slide, please. So I'm now going to talk about some of the new tools to prevent HIV acquisition, and in thinking about delivery, also think about how we can focus on equity in delivery. Next slide, please. So the ANRS presented results on the high efficacy of daily on-demand PrEP. And this was a study conducted in Paris and France, and it follows on the randomized control trial, the Epidemiology study. Next slide, please. And I want to highlight that Linda Gail Becker gave an outstanding plenary on pre-exposure prophylaxis, and I highly recommend it, although I won't talk about it today. Next slide, please. So we know that PrEP works to reduce infections for HIV, but the efficacy of on-demand PrEP in real-world settings has not been fully established. And this study is among participants with high exposure to HIV in Paris, and it was designed to evaluate the impact of on-demand and daily PrEP on overall HIV incidence and HIV incidence with each dosing strategy among men who have sex with men. Next slide, please. So this was a multi-center, open-label prospective cohort study, and participants in the study could choose whether to take daily FTC-TDF for PrEP or on-demand FTC-TDF for PrEP. And the on-demand dosing strategy was 2 doses before sex, 1 dose daily for 2 days after sex, and was a large study of 1,544 participants in the daily PrEP arm and 1,515 participants in the on-demand PrEP arm. And the primary endpoint was more than 15% reduction in new HIV diagnoses among men who have sex with men in Paris versus the rate reported by the National Surveillance Network in 2016. And the secondary endpoints were HIV incidence, PrEP adherence, sexual behavior, and safety. Next slide, please. And an open label means that the participants know what they are receiving. And you can see here in this slide, the results of HIV incidence in both arms, both for daily PrEP and on-demand PrEP. The HIV incidence rate was 0.12 per 100 person years. And so this showed that the strategy for on-demand PrEP was non-inferior to daily PrEP. And the mean follow-up was almost 2 years, 22 months. And compared to the national rates of HIV, they estimated that the overall HIV infections averted were 361. So this, in the absence of PrEP, HIV incidence in this cohort would be 6.6 per 100 person years. And next slide, please. Also very important data from this study is looking at HIV incidence. And this study, like many that I'll present today, were conducted over the course of the HIV epidemic. And you can see here in the blue diamonds, the rates of STI in the daily PrEP arm, and then in the yellow squares, the rates of STIs in the on-demand PrEP arm, and then in the white triangle, you can see the rates of STIs during the lockdown. And you can see overall, and for each STI, the rates of STIs were high, firstly, and they were comparable between the on-demand and daily PrEP arm, and they all fell during lockdown. I won't go into details here, but I can just highlight for you, for example, for chlamydia, the overall rates prior to lockdown were 31 and 25 in each arm, and then 10 following the lockdown. Next slide, please. So just to summarize the study, among men who have sex with men electing to use daily or on-demand FTC TDF for PrEP, both regimens were highly effective, and participants using, I didn't show you these data, but they also found that participants using daily PrEP had reported more frequent sex. Both regimens were well tolerated with few discontinuations, and participants remained on study, and a high rate of STIs was seen in the study. Next slide, please. Next, I wanted to present some highly anticipated data on incident infections and emergent resistance among men who have sex with men and transgender women receiving cabotegravir for long-acting PrEP. And these results were presented by Dr. Landowitz at CROI. Next slide, please. So we saw already the results for HPTN 083 showing that injectable PrEP works well to prevent incident HIV infection. And these data look at HIV infections, viral load. They also presented data on cabotegravir concentrations, but I'll focus today just on the emerging resistance. Next slide, please. So just to remind you, this was a study among 4,566 individuals who received either injectable cabotegravir or oral FTC TDF for pre-exposure prophylaxis, and the results in the next slide, please, showed very high efficacy for injectable PrEP. So 39 infections were found in the oral FTC TDF arm, and 12 infections in the cabotegravir arm with very high efficacy, demonstrating superiority of injectable PrEP. But the question, as Jehan highlighted earlier, was what happened with resistance and breakthrough cases. Next slide, please. So these additional data showed that there were 4 infections at baseline and 12 incident HIV infections observed in the cabotegravir arm. Next slide, please. Most infections that occurred in the TDF FTC arm were due to low adherence. And of the 12 incident infections in the cabotegravir arm, 8 occurred due to low adherence or low concentration, but there were 4 observed infections among participants with on-time injections and sufficient cabotegravir concentrations in the injectable PrEP arm. And the detection of HIV infection using the standing testing algorithms were delayed in patients receiving long-acting injectable cabotegravir. And this will probably result in a change in the way we screen patients before we start them on injectable cabotegravir for PrEP, and likely we will screen looking for HIV RNA, so testing for viral load. There were also integrase inhibitor resistance observed upon viremic escape, even at higher CAB concentrations. Reassuringly, these were not observed in the tail phase, but we did see some integrase inhibitor resistance for participants who acquired HIV with at higher CAB concentrations. And so these data are very important for us to think about how we diagnose and initiate ART on persons who are receiving cabotegravir for PrEP. But it was also reassuring to see that the tail phase, so the tail phase is with cabotegravir, once you have stopped receiving the injections to prevent HIV, that as the concentration of cabotegravir is falling, there were concerns that we would see emerging resistance. Next slide, please. And then I just want to end with coming back to how we're going to use these new tools to prevent and treat HIV. We did see a very nice summary from Dr. Harris on delivery of HIV care during COVID-19 in Africa. Next slide, please. And she presented that the resilience of HIV activities during COVID-19. So differentiated service delivery for HIV includes providing services outside the clinic, including home delivery of HIV medications. And you can see here that through 31 facilities providing ART, there's really, you can look quickly at this graph and see that many of the bars are maintaining the same provision of HIV testing, number of people initiating ART, number of people currently on ART, and viral suppression over the COVID-19 period. And this really helps us think that the delivery strategies for antiretroviral therapy can be robust to changes during the pandemic. Next slide, please. And then I'll just end with the study that we presented on an Amazon Prime type model where participants paid for the delivery of ART and home monitoring. And coincidentally, it took place during the pandemic. Next slide, please. And overall, we found very high viral suppression, in fact, superior viral suppression for participants who received home delivery and home monitoring of ART. Next slide, please. And next slide, please. So these data really help us think about once we have the tools and we know how to use them, we are able to deliver them. And these new tools, intermittent dosing for PrEP, long-acting injectable cabotegravir, and new delivery methods will help us address disparities in access to HIV treatment and prevention. Thanks so much. I'll pass it on to Adrian now.
Thanks so much, Ruanne and Jehan, for your great presentations. I'm going to be talking about HIV co-infections and comorbidities and data from CROI this year that were presented on these topics. Next slide, please. So my disclosure is I received grant funding from VIR for COVID treatment studies. Next slide. So the star of the show in terms of co-infections and comorbidities at CROI this year was COVID-19. Almost equal airtime was devoted to SARS-CoV-2, COVID-19 as to HIV. And I want to summarize some of the data that emerged to help us understand the interaction between these two. So what happens with COVID-19 in people living with HIV and how does the clinical course play out differently. Next slide, please. So Dr. Lee from the UK presented an abstract looking at people with HIV compared to people without HIV in the UK in the early part of the epidemic between February and May of 2020. And this was a beautiful study looking at routinely collected clinical data from multiple hospital sites, looking at patients who were hospitalized with COVID-19, comparing about 68 people living with HIV to a comparator group of people who did not have HIV, who were matched based on age, gender, hospital site, the time that they received their SARS-CoV-2 diagnosis, and a socioeconomic social deprivation index in this setting. So there were 181 COVID-19 hospitalized patients of folks who did not have HIV. The primary outcome they were looking at was time to clinical improvement or discharge from hospital. And they found that people living with HIV were more likely to have comorbidities, including CKD and end-stage renal disease and liver disease. They were less likely to have rheumatologic disease in the spectrum of comorbidities compared to people living without HIV. The key finding from this study was that people living with HIV had a longer time to improvement or discharge. So the hazard ratio was 0.57 compared to people living without HIV in the initial analysis. But this difference was attenuated after adjusting for comorbidity, age, and race ethnicity. So the hazard ratio increased to 0.7, only a 30% reduction, and this difference was no longer statistically significant. There was no difference in mortality seen between people living with HIV and COVID and people with COVID and not HIV in this group of hospitalized patients. So the takeaway from this study is that among people hospitalized with COVID-19 in the UK, people with HIV did not have significantly different outcomes compared to people without HIV after adjusting for other comorbidities. So there was a difference. It did take people with HIV longer to clinically improve or be discharged from hospital, but this was largely due to the fact that they had a larger spectrum of comorbidities, higher rate of comorbidities than their matched HIV uninfected counterparts. Next slide, please. In the US, a similar large cohort analysis was done looking at the National COVID Cohort Collaborative, which is a cohort of people who were diagnosed with COVID using PCR for the most part between January 2020 and February of 2021 in the US. And this data was presented by Dr. Sun from Johns Hopkins. This cohort collaborative pulls data from 39 centers across the US. And using this massive data set of over 500,000 cases of COVID, the investigators were able to look at the odds of hospitalization and the odds of receiving invasive mechanical ventilation among hospitalized COVID patients. And with this massive set of COVID cases, they were able to look at people who had COVID with and without HIV. So in the first table, this is a table looking at all people with COVID and looking at the odds of who had severe disease requiring hospitalization. You can see in the top row, this is again about 500,000 people with COVID who did not have HIV and did not have immune suppression due to having a solid organ transplant. In the group of people with HIV who did not also have a solid organ transplant, so the next row, there were almost 3,000 people living with HIV who also had COVID. And you can see that the crude estimates, the odds of requiring hospitalization were twofold as high for people with HIV compared to people without HIV. And this was highly statistically significant. When that estimate was adjusted for age and race ethnicity. The adjusted estimates in the first column of adjusted estimates, you can see attenuates to an increased odds ratio still of 1.63, highly significant. And then in the next column, they adjusted further for, again, the comorbidity spectrum. So adjusting for age, race, ethnicity, location, and a complement of different comorbidities and co-infections that may affect disease severity. And so we see that still there is an increased odds of hospitalization for people with HIV that persists after adjusting for comorbidities. So something suggesting it's not just the comorbidity mix alone. But with that additional adjustment, it substantially attenuates the increased risk of hospitalization from nearly twofold to about 30% increased. The second table below is a similar analysis looking at whether people with HIV had an increased risk of needing invasive mechanical ventilation with COVID compared to people without HIV and COVID. So there were about 150,000 individuals who were hospitalized with COVID and 1,421 people living with HIV who were hospitalized with COVID in this cohort. And of those, comparing the need for ventilation, for being on a ventilator, there was an increased risk for requiring ventilation among people living with HIV. Again, we can see in the crude estimate, again, close to twofold increased estimate, and that increased estimate, point estimate, held even after adjusting for age and comorbidities. So 1.86 which remained highly statistically significant with comorbidities. So in contrast to the UK data, in the US with this cohort, it did appear that even after adjusting for the comorbidity milieu, having HIV was associated with increased risk for both with hospitalization and with more severe outcomes in the hospital. Next slide, please. I then want to do a quick lightning round of a few other abstracts that were presented that looked at COVID, the intersection between COVID and HIV. These are all 3 studies that took place in the US. The first, abstract number 548, presented by Dr. Yandewa, looked at a large commercial healthcare database of about 297,000 COVID-19 cases, among whom 1,638 had HIV as well. And of note, this is a group that was highly virally non-suppressed based on their routine data. So only 48% were virally suppressed. And in this analysis, they found that people living with HIV similarly had higher odds of requiring hospitalization, severe disease requiring hospitalization, by about 26% increased odds, and had higher risk of requiring ICU level care or ventilation compared to people without HIV, though they found comparable mortality from COVID in people with and without HIV. Next, Dr. Moran looked at a cohort of 180 adults with HIV. So everyone had HIV in this cohort, and looked at outcomes of COVID in people with HIV, and found that the risk of hospitalization increased in a dose-dependent manner with the number of comorbidities. So the more comorbidities somebody had with, as well as HIV, the higher their risk of requiring hospitalization would be. And finally, we looked with a group here at University of Washington, as well as the CNIX research group throughout the country, looked at the CNIX cohort of people living with HIV, which is about almost 16,000 people, among whom we found 582 cases of COVID. So 3.6% of the entire cohort developed COVID between March and December of 2020. We did see that a disproportionate number of COVID cases occurred in Black and Hispanic people living with HIV. We saw that being female, having diabetes, and an elevated BMI were associated with having COVID among people living with HIV. We did not see any association between CD4 count and having COVID versus not having COVID. But then looking at predictors of requiring hospitalization for people living with HIV and COVID, we saw a strong association between having a low CD4 count, less than 350. The risk of hospitalization was increased by more than twofold. Age, having hepatitis C, having cardiovascular disease, having diabetes, and interestingly, having kidney disease with an EGFR less than 60, all were strongly associated with having a requirement for severe disease and hospitalization from COVID among people living with HIV. Next slide. Okay, so that was a whirlwind tour of the interactions between COVID and HIV seen in the UK and the US. I'm going to move now to TB and HIV. Up until this past year, TB was still the leading cause of mortality globally among people living with HIV. So any progress made in treatment or prevention of TB is vitally important for people living with HIV. April Pettit presented the outcomes of a study looking to shorten the duration of TB treatment for people living with HIV. And this study included both people with HIV and people without HIV, but I'm going to focus on the results of people with HIV. The design of this study was randomizing participants to one of three arms. So anyone with TB could be randomized to either standard TB treatment in the top bar, which was 2 months of 4 drugs, followed by 4 months of 2 drugs. Then there were 2 investigational arms. In the middle bar, the rifampicin drug was replaced by rifapentine, sort of a longer acting, higher dose formulation of rifampicin. And that treatment regimen was, again, 2 months of 4 drugs, then followed by 2 months instead of 4 months of the 2 drugs, the isoniazid and the rifapentine. So that's the investigational treatment. And then in the third set of treatment regimens at the bottom, that replaced both the rifampin and ethambutol with rifapentine, again, the higher concentration, longer acting rifamycin, and replaced ethambutol with the fluoroquinolone moxifloxacin. And the total duration of TB treatment in this group was, again, 4 months, with 2 months of 4 drugs followed by 2 months of 3 drugs. The primary endpoint examined in this group was TB-free survival at 12 months after randomization. So that would be a differential time since the end of treatment, since some folks had treatment that was 6 months and others had treatment of 4 months. And this was designed as a non-inferiority study with a non-inferiority margin defined at 6.6%. Next slide. So in this study, which was conducted in, I think, 6 countries throughout the world, there were ultimately 2,516 individuals who were randomized, among whom 214 had HIV. And the criteria for being included in this study for people who had HIV were that folks had to have a CD4 count greater than 100, and they either had to already be on efavirenz-based antiretroviral therapy with a suppressed viral load less than 200, or they had to start efavirenz-based ART within 8 weeks of starting TB treatment. And efavirenz-based ART was chosen due to its lack of interaction between rifampicin and rifapentine. There would be pretty significant implications for switching to a dolutegravir-based regimen. So this is all on the background of an efavirenz-based ART regimen. Next slide, please. So the key finding from this study, looking at the efficacy outcomes, so percent of people in each arm with a favorable outcome, meaning percent of people who were TB-free at 12 months after randomization. We can see in the control arm, in the per protocol analysis, 98% of participants had, and the denominators here, these are all individuals with HIV. So in the per protocol analysis, 98% of the control had a favorable analysis. In the rifapentine and moxifloxacin group, similar percentage, 96% had favorable outcome. And then in the rifapentine experimental group, so 4 months of therapy, but with only the rifapentine switch, much lower percentage of favorable outcomes, 79%. Looking at the non-inferiority data in the 2 graphs below. So the top graph of the bottom figure shows rifapentine arm compared to control. And we can see that in folks who were living with HIV, the point estimate favors the control arm, and the non-inferiority bar is crossed. So there was no evidence of non-inferiority of the rifapentine arm. But in the rifapentine moxifloxacin arm, we see that the point estimate showed significant favorability in treatment outcome. And so the point estimate we can see for HIV positive, that's the last bar on the forest plot. And the error bars do not cross the non-inferiority threshold. So it is significantly non-inferior. So the take home from here is that 4 months of a rifapentine and moxifloxacin based TB treatment regimen is non-inferior to the 6-month standard of care TB treatment regimen in people living with HIV. And this is really significant in terms of thinking about how to shorten treatment regimens for people living with HIV who also have TB. Next slide. Very quick TB HIV lightning round. I'm just going to give the extreme bullet takeaways here. We saw that in Uganda, Dr. Questrell presented a study showing that increased dose rifampicin treatment was safe and non-toxic in people with HIV who had TB meningitis, and that importantly, increased dose rifampin allowed for detectable levels of rifampin in CSF concentration compared to standard of care, where less than 50% of people with TB meningitis and HIV achieved detectable levels of rifampin. So more data will be needed to look at clinical endpoints, but I think that was really outstanding data that we will need to be moving towards increased dose of rifampicin compared to what we've been using currently. Very briefly, Dr. Sun in Taiwan presented the use of the 1 HP TB prevention regimen used in concert with Biktarvy, and found that 16 of the 50 participants had viral rebound during treatment because the rifapentine causes a decrease in the concentration of bictegravir, but all reassuringly were resuppressed at 3 and 6 months after completing the 1 HP treatment. So some debate about whether it is acceptable to use a TB preventive regimen along with Biktarvy when it will clearly decrease high risk of decreasing concentrations of bictegravir leading to viral rebound, although again, reassuringly, everyone's suppressed after. And then finally, some additional data from Amita Gupta showing that pregnant women with HIV who received isoniazid for TB prevention, who then became pregnant, so had INH exposure during the first trimester of their pregnancy, did see an increased risk of negative pregnancy outcomes, including increased risk of non-live birth. So this should result in some caution of the use of INH in early pregnancy. Next slide. Okay, I see we are at the end of the hour. So I'm going to extremely briefly talk about a hepatitis C treatment delivery study, and then leave my Hep C lightning round slides for folks to read afterwards. But I think it's really important to highlight hepatitis C treatment. Next slide. Dr. Solomon from Hopkins presented this differentiated treatment approach to hepatitis C in which participants received their full course of medication at the entry. There was no baseline genotyping, no baseline testing. There was no midpoint laboratory testing. So the study was designed to see whether people could receive a very low clinic contact, low clinic touch impact and still successfully achieve sustained virologic response with Hep C treatment. There were 2 phone contacts, but otherwise participants saw the clinician to receive their treatment, and then again 24 weeks, so 12 weeks after the end of treatment. And everyone received Sofosbuvir, which is Epclusa. Next slide. So this is about 400 participants, about half of whom had HIV co-infection. Of folks who had HIV, they were all required to have HIV viral load less than 400. Folks were excluded with decompensated cirrhosis, pregnancy, or chronic Hep B. Next slide. And the takeaway from this slide is that we can see the vertical line shows the percentage of sustained virologic response, and the vertical line shows 95%. So the forest plots around the vertical line showed distance from 95% in either direction by different status. Overall, the sustained virologic response effect in this group was 95%, which is comparable to what is seen in a higher clinical monitoring setting around the world. There were 20 non-responders, 34% of whom reported incomplete adherence. Minimal severe adverse events occurred, and none were related to treatment or resulted in discontinuing of study medication. Next slide. So the takeaway from this is that multi-month dispensing minimal interaction Hep C treatment is safe and effective for treatment-naive persons without decompensated cirrhosis, including for people with HIV co-infection in a global setting. And so this was a study conducted during COVID and was well adapted to COVID, and the investigators describe it as somewhat COVID-proof because it enables far fewer clinical contacts and is easier for the patient participant to manage their medication and is just as safe and effective. So I'm gonna stop here. Thank you so much, everyone, for your attention to HIV co-infections.
Thank you all to these outstanding speakers summarizing the data from this year's 2021 CROI. I noticed that some of you have asked some questions in the chat that and some of which have been answered by our speakers already. A couple, I think, referring to Dr. Shapiro's last talk here. One from Dr. Mara: in the TB treatment trial, what do you make of the number of unaccessible patients?
I would have to go back to the primary presentation. I think it had to do with being able to microbiologic criteria for being able to assess TB or not. So I'm not making, for the purpose of this presentation, I don't make a lot of it, but I will need to go back to remind myself what the definitions precisely of that were. Okay. And to Dr. Harrington, was there any drug resistance in those with detectable viral load while they were with viral rebound? So there was not any report of mutations seen at that time. I'm quite sure that they looked, but it was not reported in the slide if people had resistance. I think it would be certainly incomplete resistance since everyone suppressed again once they were finished with the isoniazid rifapentine. But it is entirely possible that there could have been some mutations that emerged during that time. And then there was a question about any data on different variants of concern and outcomes in people with HIV and COVID. So there is certainly data emerging that the variants of concern, Some of them have increased mortality. The variant identified in South Africa, B1351, is showing increased mortality and severity, as well as increased transmission. We did not see any large-scale epidemiologic data at CROI on the variants of concern, but I'm sure we will be in the next few weeks.
Thank you all again. I think we're over time, but thank you all for participating this morning, and have a good rest of the day.
Thank you.